The speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is CyberKnife for treating lung cancer. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can once the presentation concludes, and your questions will remain anonymous and protect your privacy as always. I'd like to introduce you today to our presenter, Dr. Joseph Cerrone. Dr. Cerrone is the director of Precision CyberKnife of New York, using state-of-the-art radiosurgery for his patients at New York Cancer and Blood Specialists in Mather Hospital. Dr. Cerrone graduated from Albany Medical College and completed his residency in internal medicine at North Shore University Hospital, which was then affiliated with Memorial Sloan Kettering Cancer Center. He later trained in the radiation oncology program at Downstate University Hospital in Brooklyn and became an attending physician at Long Island College Hospital in Brooklyn. Dr. Cerrone, you can go ahead and get us started. How are you today?
I'm doing well. Thank you so much for the introduction. I'm very happy to speak today about radiation for lung cancer. CyberKnife will be focused on the end of the talk, but it's really a general talk specifically about radiation therapy for lung cancer. And we can move on to the next slide. I look at these slides frequently, and I can do the talk in about 10 minutes. So I hope I don't go too fast. And if there are any questions, I guess you can kind of interrupt me. So anyway, current lung cancer incidence, it's the second most common cancer aside from breast cancer, and just above colorectal and prostate cancers. So it is a very common cancer, and it is something that we see in our radiation practice very often. You can move to the next slide, please. The other issue, it is on the other side, it may be the second most common cancer. It is the most common cancer causing deaths by a large margin, twice as much as colorectal cancer. And you see breast cancer, we do much better with our breast cancer patients with the yearly incidence of deaths. So it is a definite problem. It is an aggressive cancer, and we treat it very seriously when patients have lung cancer. Next slide, please. What are the causes of lung cancer? The first one is smoking, and probably if you had to do probably smoking is 1A, B, C, and D. And then the second cause can be radon gas, asbestos, air pollution, and genetics. But by far, the most common cause is cigarette smoking. And we can move on. This is just showing, and I'm putting these things in, just so that it's very important to stop smoking. November is Lung Cancer Awareness Month. Maybe we should have been doing this talk in November. But anyway, there is definitely benefits from when people stop smoking, and we definitely we talk about this with our patients. So time from smoking, 20 minutes, blood pressure gets better. 8 hours, oxygen level gets better. 24 hours, lungs clear from mucus. 48 hours, you start to feel better sense of smell. 72 hours, better breathing. Circulation improves. Breathing improves in a number of months. 1 year, less than risk in a heart attack. 10 years goes down to the base or half of the lung incidence of lung cancer. And 15 years, less heart attacks. So very beneficial. You'll feel better. One of the things it doesn't say is that maybe, people who stop, maybe they gain some weight. But there's so many other better health benefits. So we definitely recommend it all year round and with any of our patients. You can move on. How does the patient present for lung cancer? And the symptoms are very varied, and they can be none. Is it generally shortness of breath or cough? That's probably the most common one. Can you have some chest pain if you have a larger lesion or fatigue? So these things, coughing up blood is a common one too, but sometimes you don't have to have any of these symptoms for for the patient to present with lung cancer. Sometimes we see it incidentally if someone's having a chest X-ray or having testing for a different problem. So, but these are the main ones: fatigue, cough, shortness of breath, chest pain, loss of appetite, and hemoptysis. So something that we look for or how patients present. Generally, they go to a pulmonologist or their primary physician first. Next slide, please. So this is something that's very in vogue right now, is screening for lung cancer. And patients can have a low dose CAT scan, no contrast, it's very fast. It's so there are specific indications from the CDC patients who can have screening CAT scans. You have to have a 20-pack year cigarette smoking history. What's that? That's smoking 1 pack a day for 20 years. And that's really an easy criteria for many smokers who started smoking when they were 15 or 20 years old. They have to be a current smoker or quit in the past 15 years, and you have to be between ages 50 and 80. So these things, we are looking at these and offering it to many of our patients in our oncology office, but the primary medical physicians and pulmonologists are also screening for lung cancer, and it is a nice thing to do, and we'll get into that just a little bit later. So really, what's the benefit if you have a screening for lung cancer? You find the disease earlier. You can have better options, you have better control rates. So it can end better survival rates. So it is important. It's something that we're seeing much more often right now. Next slide, please. And of course, like I said, trying to quit smoking. What are the options to try and quit smoking? Most common is nicotine replacement therapy, a patch or inhaler, nasal spray. They do work. You have to be they do have some side effects. So all of these things, can work, and you have to be motivated to do these things. Medications such as Zyban and Chantix also can work. Alternative methods, hypnosis, acupuncture, and a herb called lobelia. So all of these things, each patient can have its own thing that works for them, and some of them do work in certain situations. The e-cigarettes, though, is not considered a smoking cessation vehicle. It is really an alternative, and we'd rather prefer you use any of these other options. So we do recommend these things when we talk to the patients. So now let's get on to talking a little bit about lung cancer and how we look at lung cancer, how we treat lung cancer overall. Specifically, 3 main types of lung cancer. 75 to 80% is non-small cell lung cancer, about 20 to 25% small cell lung cancer, and a very small percentage is a cancer called mesothelioma, which can be associated with asbestosis and smoking together. So it's a whole different logarithm how we treat this, so we're not going to go into this that much today. But non-small cell lung cancer, the most common cancer we see, typically adenocarcinoma, squamous cell carcinomas, the large cell cancers, all treated similarly but differently in certain situations. Small cell lung cancer, people consider it a diffuse disease, but still can be localized and be treated very well with chemo and radiation. Next slide, please. Just an example, if someone has a screening CAT scan, this is what we consider early lung cancer, and something that we can treat very readily with CyberKnife or surgery. And we'll get into that a little later. So this is something we can see on a screening exam, which is very easily to treat and has very good success rate and high survivals. Next slide, please. This is kind of intermediate lung cancer, where the patient, this is generally inoperable, where there's a large lung mass and there's disease in the mediastinum or it lights up centrally. This is likely stage 3 disease. We see this in about 75% of our non-small cell lung cancers. Just as a side, this is an example of a PET scan. A PET scan we generally get on all our lung cancer patients just to see where the disease is and to make sure it's only localized in the lung or is it outside the lung, and that can make a determination on what we call staging the patient and to give the correct treatment. So this is a PET scan. It lights up the area where the disease is. They give you a glucose molecule attached to a radioactive isotope. It goes into the cancer and it stays there, and that's why it lights up. So there's the area in the lung, and then centrally is where the disease is in this patient. Again, we use PET scans frequently for staging our patients. Next slide, please. And this is an advanced or a late lung cancer. It's locally advanced. It could be into the chest wall. It's involving the mediastinum and very bulky disease. These we would get a PET scan with these or the other cancers. And frequently, if it's this far advanced, it can have what we call distant metastases or disease in the liver, bone, or brain. So this is treated, differently, and it has its own protocol for treatment. So we can move on, please. So what happens when the patient comes to the radiation consult? The patient is generally been seen by the patient's primary doctor or pulmonologist. Generally, a biopsy has been performed. We take a full history and physical of the patient. We review the radiology, we review the pathology, and then we use then we give the patient a stage of disease. Is it a stage 1 through stage 4? Stage 1 is like an early stage disease. Stage 2 is really just a hilar area. Stage 3 is more advanced disease. And then stage 4 is when the disease is outside the chest wall and metastatic. So once we stage the patient, we make a determination on the course of treatment. Next slide, please. So this is, like I said, the staging protocol. The patient is staged by a tumor, a nodal, and metastatic areas. And once we put a number in, 1, 2, 3, or 4, we add these up and put them in a disease stage that's appropriate. Once we get this, you can move on. We like to use this NCCN guidelines to help us with the current guidelines. It is a site that has all cancers, it has all stage of cancers, and it gives recommendations for up-to-date treatment. So it is helpful. Sometimes it's helpful to show the patient exactly what we're doing and what the recommendations coming from. It has all the top doctors in the country and make recommendations for each stage of cancer, and then we can follow these with being specific for each patient and their physical needs and their stage of disease. You can move on. So this is just an example of what we look at with the NCCN. It has each stage. You can see stage 1 through stage 2, stage 3, and then it gives treatment recommendations. You can move on. And again here, so on the left side, it shows the stage T1 through 3, T1, and then it shows resectable. So it gives us, again, treatment options. We go through this with the patient to make sure that we're all on the same page and given the correct treatment for where we're at this time. You can move on, please. So what happens when we see our patients with non-small cell lung cancer and we formulate a treatment plan? Like I said, most commonly, we see unresectable non-small cell lung cancer patients, and that's stage 3, where the disease is in the lung and also in the mediastinum. So we also see patients who are post-operative treatments, who have had surgery for whether a small tumor and then possibly need radiation to either that area where it was taken out or to the mediastinum or hilar areas. And more frequently, we've been seeing inoperable small tumors or small tumors in general, since patients are being screened more frequently or being followed by their pulmonologist for small tumors. And then, of course, we treat patients for palliation of metastatic disease. Unfortunately, some patients present with distant disease where they have disease outside the lung, either in the bone, the brain, or the liver, and we treat those to help the patient's symptoms. Next slide, please. This is just a real quick study to show comparing different chemo and radiation regimens and what we do, why we do this. So now the arm 2 had the higher median survival and overall survival. So that's why we use concurrent chemoradiation, followed by, and now more frequently followed by immunotherapy, for our unresectable non-small cell lung cancer patients. You can move on, please. So exactly what is immunotherapy? So we know what chemotherapy is. It's cytotoxic medication given through the body that attacks the specific tumor cells at different levels of the molecular site of the cells. It could be the mitochondria, it could be the DNA, different areas to kill the cancer cells. Immunotherapy is slightly a little bit different. It's agents to promote cancer death by stimulating the patient's immune system. It really has different side effects than the chemotherapy. Instead of dropping the counts and impairing the patient's immune system, you can have rashes, allergic reactions. The most common immunotherapy uses Imfinzi or desilumab, and that's what we use after the chemoradiation. And it's really been groundbreaking in that the patients are having much longer overall survivals with these new medications. We also can use Keytruda or Opdivo, different agents with different genetic markers for the tumors. And it's been really beneficial in our lung cancer patients to use these additional agents. Next slide, please. So what's the standard treatment course for this locally advanced lung cancer? It's 6,000 centigrade in 6 weeks. We treat with IMRT/IGRT technique. Sometimes we can push the dose up to 66 or 7,000 centigrade. The standard dose is 6,000 in 6 weeks. Postoperative radiation, generally 5,000 or 6,000 in 5 to 6 weeks. And then palliation of bony disease, brain disease is generally less, so we don't have to give a definitive dose. So anywhere from 4 to 5 or 10 fractions. What are the main side effects when we treat these patients for lung cancer? The main side effects could be cough, skin irritation, rib irritation, but the most troubling one is esophagitis. If the disease is in the mediastinum or central part of the chest, they can have trouble swallowing, and that could be uncomfortable during the treatment. But we generally manage this, and patients generally been doing much better. You also can get pneumonitis or inflammation of the lung, cough, and shortness of breath. Even though we treat a large area of the lung, it's rare that they get symptomatic. They can have scar tissue, but it's something that we do look for and we do manage. Patients, of course, are going to get fatigue if they're getting chemoradiation. So generally, we see the patient once a week. We manage whatever side effects they have and hopefully get them through the end of the course. Next slide, please. So just moving on to small cell lung cancer. It's staged the same as non-small cell lung cancer, but generally we break it into limited stage or extensive stage disease. Limited stage is about 30% of the presentation. It's limited to one radiation portal. So it could be a small area on the chest or mediastinum. It could be a larger area, but generally that is treated with chemotherapy and radiation. Where extensive stages, the disease is outside the chest, chemotherapy is the primary treatment. I put this on the bottom here as PCI, or what we call prophylactic cranial radiation. It's used with small cell lung cancer to decrease the incidence of brain metastases, as there's a very high incidence of brain disease through the duration of this illness. But it's only used basically in limited stage patients to decrease the brain disease from 60 to like 30%. So it is beneficial. People get nervous because we're treating the brain, there's no disease there, but it still is a relatively low dose and it can be beneficial to the patient. Currently, we're using something called hippocampal sparing, where we spare the central part of the brain, which can be memory related. So patients are actually doing much better with the new technique that we're using. You can move on. And then this is just a study showing why we do what we do for limited stage small cell. It compared once a day treatment to twice a day treatment. And you can see in the arm 1, where the 5-year local control was 64 versus 48%. And that's what we do offer the patients, twice a day treatment for 3 weeks versus once a day treatment for 6 weeks. But some patients, it's hard to come for, 3 weeks, twice a day. So we still use the once a day treatment, and patients still do very well. Next slide, please. So what happens when we get a game plan? We're going to say, let's start. We know where the disease is. We did our PET scan. It's localized disease. We do what we call a simulation and treatment planning. The patient comes to our office. We have a CAT scanner right in our office, and we use what we call respiratory gating to see how the tumor moves when they're breathing, and we can circle all where areas of disease are at. Next slide, please. So we circle the disease, and then we put on a field to encompass the radiation area. This actually is an older technique that we use called 3D conformal treatment, where we treat it from the front and the back, and all of the tissue in between these get the high dose area. Currently, we do 99% of the patients with IMRT, so it's IGRT technique. Next slide, please. So this encompasses a multi-leaf collimator where the block is in the head of the linear accelerator, and it can move with how the beam is being produced from the head with the radiation being produced. So we can modulate the beam as it's coming out. So we can, instead of going from the front or back, we can use 5 or 7 different beams that are modulated to minimize the dose to areas we don't want treatment and maximize the dose to the areas we do. So this changed our life about 20 years ago, and this is what we do right now. Next slide, please. So this is an example, just an IMRT technique, where you can see the high dose area is really focused to just that left-sided tumor mass. There is some low dose area around it, but really of no consequence to the patient. So better issues with less pneumonitis, less swallowing. Patients do much better with this IMRT/IGRT technique. Next slide, please. And then just an aside, for informational purposes, there is a treatment with proton therapy. Maybe people have heard of this. It is a different radiation technique. It has a proton beam, which we're able to stop the beam after a certain amount, or what we call it, how deep it to go. So you can see on the diagram on the right that the proton is very conformal treatment, minimal scatter around it, where the IMRT plan has low dose around it. Now, again, not causing any real issues. The high dose areas are very similar, but the low dose is less with the proton. So the issue with the proton is there's only one machine here in New York. The closest one is the Upper West Side of Manhattan. So to treat all our lung patients on this would be impractical. But for certain situations, it can be beneficial to the patients in retreatment. So this is really just for educational purposes. Move on, please. And again, this is showing the dose distributions or the dose areas for how we used to treat. So conformal radiotherapy, and each one has little less and less of the dose bath per se, where you see the proton is less than the IMRT, which is less than the conformal therapy. So we are getting more conformal, but sometimes with these larger tumors, we still have to treat a large area, and patients can still do very well with minimal detriment to their respiratory status. So we're just getting better and better at doing these lung cancer treatments. So this is an example of our linear accelerator, one of the linear accelerators we have. It does have that CAT scan capability on each to do before the treatment. We line the patient up, we see exactly where the mass is, then we give the treatment. Treatments can be given in 5 to 10 minutes, for Monday through Friday for about 6 weeks, and we manage the side effects. Patients can do very well. This is like a true beam, and patients do very well with this machine. In Patrick, we have a different type linear accelerator. It's more of a CAT scan type unit, but gives very similar treatment, very quick treatments, very precise treatments. So this is really what you wanted to hear about, the CyberKnife for lung cancer. And this is what we'll talk about now. This is our CyberKnife unit. We had an older linear accelerator in this room here on Belmead Road in Setauket. We switched it out for this latest and greatest CyberKnife machine. It's just, we've had it now for almost 7.5 years. It's just improved the treatments for many, many patients in our area. And we're so happy that we're able to use this, in our patients. So next slide, please. What is CyberKnife? Radiosurgery? No, it's not surgery. It's radiation, precise radiation therapy, non-surgical treatment. We can treat patients anywhere in the body, and we've just about done that. It's multiple non-coplanar beams aimed at a specific tumor with minimal or no margins. Examples: brain, spine, lung, pancreas, liver, prostate, and really sites where there could be other disease in the body. Next slide, please. So specifically, so for these other lung cancers that I was talking about before, locally advanced, we can't treat this with CyberKnife. CyberKnife is generally treating tumors that are definitely 5 centimeters, but specifically 3 centimeters or less. So for early stage lung cancer, most commonly seen in patients less than 70 years old. Generally, the patients are seen by the pulmonologist and then sent for surgery evaluations. Most common treatment is a lobectomy, and the local control rates are better than 70%, probably 80 to 90% over with a good resection. The unfortunate thing is that 20 to 30% of these patients are inoperable, meaning they have really bad pulmonary function, they have heart disease, they can't undergo the surgery. So what's the best option for them? Previously, we tried to treat them with standard radiation or external beam radiotherapy, but we had suboptimal results where the local controls were less than 70% and the side effects were higher. So we have better options now, particularly with CyberKnife. Next slide, please. This is really the study that brought lung cancer to the attention of many people. So with CyberKnife treatment, we treated with 3 to 5 fractions. It was a protocol, 55 patients, 3-year survival, 3-year follow-up, and the local control in the last line on the bottom, 90% for these patients. The larger tumors had distant metastases, but overall the control was 90%. In other words, you can do this not only in inoperable patients, can you do it in operable patients? Let's move on, please. So this is an example of what happens when the patient comes for the planning. We see a small tumor and we do the planning with the CyberKnife. We can see this tumor is very close to the heart. That's the pink structure all the way to the right. And still, we can treat this small tumor with a nice little margin around it with minimal or no dose to the heart. We still get some rib dose, so patients can have some rib discomfort or skin irritation, but still very small focus, shouldn't impair their breathing, even when they have limited, some limited breathing already. So very small area, very high dose of radiation, very high control rate. Next treatment, please. Just move back. So the CyberKnife treatment is different than the standard radiation treatments. Each CyberKnife treatment takes anywhere from 30 to 45 minutes, where standard treatment takes 5 to 10 minutes. But still, only 3 to 5 treatments is generally give. Treatment's done very quickly, very easy and painless for the patient. Next slide, please. So I did go to a radiotherapy conference where the lung surgeon and the radiation oncologist were debating, can radiosurgery be used in patients who can have an operation but decide not to have the operation. Next slide, please. This is just a few graphs, but it really shows on the bottom one that the local control for inoperable and operable patients is essentially the same, 85%, 87%. So they do get the same control rate, even though the inoperable patients don't live as long because they have other severe medical problems, but the control rate is the same. Next slide, please. So there was trying to do a study comparing radiosurgery to surgery, but it was very difficult to do. So they had these small studies, they put them together, and you can see on the left that the blue line is the control rate or survival with the radiosurgery, and the red line is with the surgery. And patients do very well or better with the radiation, even if they could have the surgery. And the recurrence-free survival is on the right side, again, where the blue line is above the red line, or at least is equal. So the control rates also were very good, even at 3 to 5 years. So it is something that can be done. I'm still not ready for prime time. You can move on, please. So what does the surgeon say? The surgeon says, well, we can take the tumor out. We get pathologic staging. We get lymph node evaluation. We get molecular analysis to see if the patients can be given immunotherapy. We have longstanding clinical experience. We look at it better with the CAT scan. If you have a follow-up CAT scan, you don't see anything there. But with the radiation, sometimes it gets bigger, sometimes it gets smaller. It's a little bit, a little variable. So still, generally these lung operations are performed with minimal morbidity. Right now, they're doing what they call a VATS procedure, or video-assisted thoracic surgery. And it works very well. It's very minimally, patients are in the hospital overnight versus to an open procedure where they're being in the hospital for 3 to 5 days. So much easier surgery, but still can be treated with radiation. Next slide, please. So standard of care, inoperable cancers is for patients to receive stereotactic radiosurgery. And we saw that this can have a very high control rate. The current standard of care for operable cancer is lobectomy. But we saw that there's very encouraging results with stereotactic surgery itself. And this may come to fruition, sooner than we think. Next slide, please. So this is what we hope we see when we treat somebody with lung cancer. We do a follow-up PET scan. You can see on the left side, the patient has a pretty good size left upper lobe, non-small cell lung cancer, and it was treated with chemoradiation. You can see there were small lymph nodes associated with that. The follow-up PET scan performed a few months after treatment shows no evidence of disease. Minimal scar area, no uptake on the PET scan. So this patient had an excellent result, and we hope it's a durable response, and we hope the patient is doing very well. Next slide, please. How do I end up? These smokers, we talk to them, you still should quit. You'll live longer. Your cholesterol improves. You'll look better. You may gain weight, but that's something that we don't talk about. And your smile is better. Overall, it's better to quit. So next slide, please. So I'm done, and I hope I didn't go too fast. So I appreciate your attention. Thank you.
Thank you so much, Dr. Cerrone, for taking the time to present with us. That was fantastic. If anybody has any questions, we'll give it about a minute for anybody to enter those. Dr. Cerrone, why don't you just talk us quickly through what the process is to make an appointment with you guys? You call and there's a CyberKnife coordinator, there's somebody at your cancer and blood specialists that can help get the appointment going, right?
That's correct. It's either way. We'll get a call from the patient's pulmonologist, primary doctor, referred, or medical oncologist referred for radiation consult evaluation. Generally, they'll know which one, whether it's specifically for CyberKnife or specifically for radiation therapy. Still, even when the patient comes in for CyberKnife, sometimes they may not be a candidate, and we go with regular radiation. So we do the assessment at the time of the consultation. Some people they hear about CyberKnife. I just want CyberKnife. You have to be a candidate. You have to be, you have to have a small enough lesion. You can't have disease outside. But some people, when we do the staging, it changes, what we're going to recommend. So we do see the patient either in our regular office or in the CyberKnife office. and then we treat the patient appropriately.
Okay, fantastic. It doesn't look like we have any other questions, so I'm going to let you go a little early. Thank you, everybody, for joining us today. You'll be receiving a brief survey, so if you could please fill that out, we'd really appreciate it. We'd just like to know what else you'd like to learn from us here at Mather Hospital. And Dr. Cerrone, please enjoy the rest of your day. Thanks so much.
Thank you so much.